and this lecture today on in-flight medical emergencies. So I have no actual or potential conflicts of interest in giving or presenting today's material. And wanted to start off with a case, and this is how I became interested in this topic, is from being involved in a few in-flight medical emergencies in the past. So we'll get back to this case kind of towards the end of this lecture, but wanted to kind of start here. So this is on a flight from Charlotte to Phoenix, which is around a 4.5-hour flight. And near the end of the flight, there was an announcement over the overhead asking for a medical professional to help with an emergency. Upon meeting the flight attendant, she reported that there was a middle-aged male that was having symptoms of dizziness, feeling like he was about to pass out. And when I went back to evaluate the patient, he was awake and alert, but appeared pale and was a bit diaphoretic. So that's kind of getting us started here with our lecture. So coming here today, listening to the lecture, what is it that I just want you all to just take a second, just kind of reflect what you want to know about in-flight medical emergencies, if you were kind of called to respond to one. So just thinking about that. Seeing stuff in the chat. So what I kind of, as this was evolving and as I kind of walked away from this experience, these are the things that are kind of running through my head. So one was, what even happens during these emergencies? Like, what's the process, pilot, flight attendant, and my involvement in it? What resources do I have to help the passenger? Am I going to have to decide to divert the plane? And what is my liability? So that's really what we're going to kind of touch upon and explore with this lecture. So by the end of the lecture, learners will understand the frequency of in-flight medical emergencies. They will recognize in-flight physiologic changes that can contribute to these emergencies. They will identify the most common in-flight medical emergencies, understand the process of initiating and managing an in-flight medical emergency. Learners will identify available resources on the plane and on the ground for helping manage these emergencies. And finally, learners will understand medical legal protections that exist on domestic and international flights. So in terms of true incidents, it's kind of unknown, and there's reasons for this. So one, there's not really a consistent definition of what is an in-flight medical emergency. And to date, there's no mandatory reporting system for in-flight medical emergencies. These are better reported domestically within the United States than they are internationally. But what we do know is that the frequency appears to be increasing. So there are a few different reasons for that. So one, there's more travelers. So going back about 20 years, there was about 1.9 billion travelers per year worldwide. Whereas if you look at 2020, 2019, 2020, 4.7 billion travelers per year. And interesting to see this, like this COVID blip here for a few years. And this is back in 2022, so there's not accurate numbers for the last 2 years, but probably it'll take a long time to get to like pre-COVID, directly pre-COVID numbers. And part of that is probably because of just travel implications of COVID around like kind of business and things like that. I don't know if people will ever travel for business like they previously did before COVID. We also have older travelers. And then improved mobility of patients with chronic disease. So patients able to have oxygen concentrators on airplanes, patients with trachs being able to go on airplanes. So we have patients with significant chronic disease that have the ability to travel more than they previously did, which puts them at a higher risk of having an adverse event. I referenced this study quite a few times out of the New England Journal of Medicine. It was published in 2013, so a little while ago, but a really well done study looking at some of the physiologic reasons for medical emergencies and then also outcomes and what was going on with these emergencies. And even though this is a few years old, even in the literature that's been published in the last 5 years, they're commonly referencing this article. So Out of this article, they reported that there's about one in-flight medical emergency for every 604 flights, or around 24 to 130 emergencies for every million passengers. So that's going to be quite a big number since we're describing about 4 billion passengers per year. So putting that all together, that's 260 to almost 1,500 emergencies per day globally. A majority of these emergencies are actually handled by the airline crew, about 75% of them, and it's only about a quarter of the time that medical assistance is requested. And there's significant implications, of course, of these emergencies, especially around flight diversion. Of course, part of that is inconvenience of other travelers, but really there's huge cost to divert a flight, upwards of $725,000 for some flights. And that's going to depend on where the flight is being diverted to, if fuel has to be dumped, the size of the plane, passenger accommodation needs. In reality, only about 4 to 7% of in-flight emergencies require a diversion. And then the most common reason for a diversion to be triggered is because of the passengers having cardiac symptoms. There's significant in-flight environmental stressors that really can be linked to the majority of what's going on with a lot of these in-flight medical emergencies. Commercial flights are generally flying at 30,000 to 40,000 feet, and the cabin is pressurized on average to 10.9 psi, which is the equivalent of 8,000 feet elevation. They can't be pressurized higher than that to a lower elevation or higher psi. Because at a high altitude like that would actually potentially jeopardize the integrity of the fuselage. So 10.9 psi is kind of the standard cabin pressure. What we're going to focus on today is primarily around lower oxygen, lower atmospheric pressure. But there's also implications of lower humidity in the cabin, air turbulence, and prolonged immobility. So from a humidity standpoint, optimal humidity for someone to kind of function is around 40 to 70%. And in a pressurized dehumidified cabin, the humidity is around 10 to 20%. So that can contribute to dehydration, that can have pathology kind of implications for sinus dysfunction or inner ear dysfunction. Air turbulence, of course, can lead to passenger falls or trauma from items within the aircraft striking someone. And then prolonged immobility, of course, can increase the risk of DVT. So for lower oxygen, you remember back to physics and Dalton's law, which describes the relationship between atmospheric pressure and the particles within that, partial pressure of the particles within that atmosphere. So as elevation increases, PSI or partial pressure in the atmosphere decreases. And the lower PSI reduces pressure that's restricting gaseous kinetic energy. So that promotes gas expansion, more gas movement, making the air less dense, and then that lowers oxygen in addition to other molecule concentration within the air. So if you look here at altitude, at sea level, partial pressure 760 millimeters of mercury, or PSI of 14.7. And then the PaO2 is going to be, for a normal patient without lung disease or cardiovascular disease, it's going to be 80 to 100. And then at cabin pressure, which is again around 8,000 feet, PSI 10.9, and then the partial pressure actually drops to 60 in a healthy individual. So for someone that has no significant chronic disease, you can see on your oxygen dissociation curve, partial pressure oxygen of 60 still keeps you, in the low 90s for your PaO2 or your oxygen saturation. Your PaO2, of course, is your partial pressure of oxygen in the blood. So a normal patient is or passenger is going to have 80 to 100. But if you have chronic lung disease like COPD, like bronchiectasis, asthma that's flaring, your partial pressure is going to be lower. And you can imagine if you're living at sea level with oxygen saturations in the low 90s, and a partial pressure of oxygen in your body lower than 80, you're just going to shift further to the left on this curve, in the steeper part of this curve, and going to have more issues with that cabin pressure being at 60. So these patients are going to be prone to becoming hypoxic. There was a study done that looked at passengers' oxygen saturation in the airport, and found an average of like 97 to 99%. And then they looked at their oxygen levels in the cabin, and it was 92 to 94%. So that's what you really expect someone's like a healthy individual's oxygen to be at cabin pressure, around 92 to 94%. Another kind of physical law here is Boyle's law, which is the relationship between pressure and volume. So at 8,000 feet, there was a 30% expansion of gas in an enclosed space. And my brother learned this the hard way on a family trip way back when. We wanted to bring a football, and he had it kind of filled up for the trip. And by the time we landed, it looked more like this. So as pressure, pressure decreases, volume, because of that reduced restriction on that kinetic energy, volume increases. And for human implications, this can be a big contributor of like why we see a lot of GI disturbance. A lot of air within the bowel expands, and that can cause a lot of discomfort. But also can cause issues with sinus, middle ear, and is the major reason why patients that have had recent surgery, ocular procedures, have had a recent pneumothorax, have specific restrictions around when they can fly again. So more like clinical application of this. So this was a case report from the Annals of Internal Medicine in 2020 of a patient that developed acute Bell's palsy. So what happened here is shortly after takeoff, medical assistance was requested for a patient that acutely developed facial drooping and slurred speech. So the flight attendant was able to get a hold of a medical provider, and they conveyed concerns about the patient having a stroke. On exam, the patient was noted to be a young and fit appearing, and the patient described acute onset of a left-sided headache followed by facial drooping, inability to close that eye, and then slurred speech and drooling. The exam was notable for, in addition to the above, loss of forehead wrinkle. All the other cranial nerves were intact. There were no other neurologic findings for the patient. And the patient reported to the provider that they had recovered from a head cold a couple days before. So what happened here is this patient acutely developed Bell's palsy related to dysfunction within their eustachian tube. So what happened here is that gas gets trapped and expands. They're getting over a head cold, so their eustachian tube may have been kind of plugged. They're a little bit inflamed. Gas gets trapped in the middle ear, and then put pressure on the tissue and the blood flow near the facial nerve, resulting in a Bell's palsy. And similar cases have been reported. This is just one that I found. And generally, this is a very transient thing. It's going to resolve quickly with swallowing or chewing. And most often, you're going to see this kind of right as you're reaching elevation after ascent. So kind of more physics here. So there's different zones based on altitude, and there's the physiologic efficient zone, physiologic deficient zone, and then the space equivalent zone. So majority of the world is going to live in these physiologic efficient zones. So even our highest kind of major city, which is La Paz in Bolivia, is at an altitude kind of right at the border of that physiologic efficient zone. And there are actually a few other settlements that are actually near like 15 to 16,000 square feet. But again, a majority of people are living under 12,500 feet. And as you kind of reach the border of this, as you get nearer and nearer to 12,500 feet, that's when you are more likely to see issues with minor issues with trapped gas, whether it's causing ear and sinus issues like we discussed, or GI tract issues. As you get into this physiologic deficient zone, which is where your planes are going to be flying at, this is where you see more significant issues with hypoxia and decompression sickness related to Dalton's and Boyle's law that we kind of already talked about. And of course, space equivalent zone is just not compatible with life. Nitrogen in blood will boil, and it's no good. So why should I put on an O2 mask on myself before putting on, someone next to you, your child? So even an extremely fit athlete, so we have Steve Prefontaine here. So any runners in the group know he's kind of in the 70s, like the beacon of fitness. So even an extremely fit athlete would fall unconscious within about 10 seconds at 35,000 feet if the cabin became unpressurized. So in putting together this lecture, I was able to speak with a pilot. Southwest pilot has 35 years of experience flying Boeing 737, 140-ish passenger plane. In his career, he reported that there's a total of 2 in-flight medical emergencies that he actually had to divert the flight for. So you're talking about thousands of flights, and only 2 times did he ever have to actually divert the flight. He's, of course, had many more in-flight medical emergencies, but never requiring diversion. And then he never experienced an in-flight medical emergency that didn't have some medical professional or first responder that was available to assist the passenger. And he really, and we'll get into this kind of towards the end of the lecture, really stressed the importance of how much airlines appreciate any sort of assistance from any medical professional, no matter kind of where you are at in that spectrum, and that they really want us to think, they really feel like it is their passenger, not our patient. So we'll kind of talk into how that relates to major decisions as they get made. But it was helpful to kind of get their insight in putting together this lecture. And also talk about this right here. What is the process of what's going on here? So when an in-flight medical emergency is identified by a flight attendant, the first thing that they're trying to decide is, does this patient need to be evaluated by a medical professional? And if that's known, that flight attendant is going to manage that situation. So again, this is going to be about 75% of the time that the flight attendant is just taking care of the patient or the passenger themselves. If they feel like this does require help from a medical professional, first thing they do is update the pilot, and then they'll do a PA announcement for medical assistance. If the patient requires further medical intervention, if they need medications, maybe an IV line, if they're unstable, that's really going to trigger, in most cases, this call to radiostat MD, which we'll talk further about. So ground medical aid. And if not, if the patient just kind of needs further evaluation, minor interventions, that medical professional can kind of continue management. And if the patient remains stable or is clinically improving, kind of no further things need to be done, and the plane will proceed to its final destination. If the patient becomes more unstable or the provider is concerned about the patient's clinical condition, that can, again, trigger this call to StatMD. And StatMD is going to help manage that patient with you, and ultimately be the one that helps making the recommendation of whether the flight needs to be diverted with the pilot. In the end, no matter who makes that recommendation, it's up to the pilot to kind of decide, and we'll talk about that a little bit further as well. The only little caveat here is international flights don't always have contracts with ground medical, and sometimes you can be in the air and then the airline struggles to get a hold of someone on the ground. So sometimes you are helping to make some of these decisions, or kind of continuing to lead the medical care. But certainly domestically, usually you're having ground medical that's kind of assisting in these scenarios. So what tools am I immediately going to have in the air? So the FAA requires that all flights have at least one first aid kit and one emergency medical kit, and then that all flights are equipped with an AED. Um, the FAA has like kind of a minimal requirements for these medical kits. And most of what's in here, in addition to kind of what we just talked about, is things to be able to do that initial assessment and take vitals, needles and syringes to draw up certain medications, catheter and IV lining to place an IV for fluids. And then there are kind of depending on the airline, certain airway kind of management tools. So most often this is going to be an LMA. It's not common, especially on a domestic flight, that there will be like endotracheal tubing and things to be able to actually intubate a patient. This might be on some international flights if they have an expanded medical kit. But most of this is just kind of initial interventions to kind of stabilize a patient. And then in terms of medications, antihistamines, aspirin, atropine, bronchodilators, epinephrine for coating a patient or anaphylaxis, dextrose, lidocaine, nitroglycerin. So not a super broad medication list, but enough to handle most medical emergencies, especially the ones that we're most commonly seeing. I did, just kind of for completeness sake, kind of include the dosing for anaphylaxis for adults and children. Things that are likely not going to be available. Pulse oximeter, these are becoming more common, but they're still not like an FAA regulated minimum thing. And then pediatric intravenous kits and sometimes pediatric airway kits are not available. In these more expanded emergency medical kits, these are going to be more common on longer international flights. And the kind of the what you're going to see here more often is things around obstetrical care. There's usually more in terms of airway management. And then there's more availability for medications in terms of, usually they'll have benzodiazepines. These kits almost always have naloxone, although all domestic flights I think are going that way now, which is surprising that it's not there. It's not common that there are narcotics in these, even in these expanded kits. So I kind of initially introduced this idea of the StatMD. So what this is, so StatMD is the most common ground medical resource that airlines domestically are using. It's a service that's out of Pennsylvania, actually. I think it's a call group of ER providers. And their job is to take call to respond to in-flight medical emergencies. So every domestic US airline has a contract with this or a similar organization. And then most larger international airlines have similar setups within their own country. For breaking down actually what are the most common in-flight medical emergencies, neurologic is overwhelmingly going to be the most common. This really should be split into like stroke-like or pre-syncopal, because it's really pre-syncope and syncope that is the majority of these, and stroke-like is kind of further down in terms of frequency. This is a JAMA systematic review. It includes that New England Journal of Medicine article that we referenced earlier, and then a few others. But this JAMA review is essentially put together to kind of reflect on what the most common in-flight medical emergencies are, and then developed kind of a framework of how to work up each of those problems and manage each of those problems, which we'll kind of talk about in the next few slides. But the overwhelming majority of the time, patients are going to be dealing with syncope and near syncope episodes, followed by GI and respiratory disease, and then kind of cardiovascular further along. The least common thing is cardiac arrest. However, this is going to be the most common reason that a flight is diverted. part of this Peterson study that was interesting to me, when they were looking at GI in-flight medical emergencies, they looked specifically at nausea and vomiting and found that in the case of nausea and vomiting, if antiemetics were given, there was 0.9% of the time the flight was diverted. And if they are not given, 5.4% of the time it was diverted with a p-value of less than 0.05. So the takeaway from that is if you do have a patient that's having any sort of GI distress, nausea, first thing you want to do is give them Zofran, Phenergan, and get that nausea under control, give them a little bit of fluids. But yeah, just kind of an interesting stat from that article. The other part of that JAMA systematic review was these like pretty helpful breakdowns of essentially your differential for syncope, near syncope, and what you should be doing in management. And then they did this for cardiovascular symptoms, cardiac arrest, GI, respiratory, all these different things. So if you ever get a chance, it's a kind of an interesting read. I kind of threw all these into an Evernote that I have kind of available if I ever needed it on a flight. But kind of out of the scope of this lecture to kind of break down each and every one of these. So next thing is our breakdown of medical legal implications. So in the United States, there's protections under the Aviation Medical Assistance Act of 1998, which essentially can be broken down into, it's very similar to the Good Samaritan Act, which essentially if anyone is responding to an in-flight medical emergency, it is presumed that they are doing this of good intent. And as long as they don't do anything egregious where there's clear gross negligence or willful misconduct, that they have significant protections if anyone ever did try to sue them for their care. And they term medically qualified individual. They further break that down into anyone, including a physician, nurse, PA, paramedic, emergency medicine technician. So the US, Canada, England, and Singapore don't have any laws requiring a professional to respond to in-flight medical emergency. And most countries actually align this way. But there are a few countries, Australia, many European countries, Europe, Germany, France, that actually do have laws that require a medical professional to respond. They're not really enforceable. The overarching thing here is that it is ethically best to kind of respond if you're in a place that you can respond to in these scenarios. Flying domestically, whether you are on a US or a non-US owned airline, you're covered under the AMAA. And then if you're flying internationally on any US owned airline, you're covered similarly under the AMAA. Where things get tricky is if you're a US citizen and you're flying on an airline that either non-domestically or that's not a US airline. Many countries have very similar laws as the AMAA, but coverage there can get a little bit tricky. So in some countries, you might, just because you're a US resident, fall under the AMAA, and then other times you might fall under the airline, or you might have coverage within that country. So what are the actual, I think we hear all those things and we're like, okay, I guess I have coverage, but like, what's the real risk here? What has historically been done? So to date, there has been one lawsuit made against a person that was responding during an in-flight medical emergency. Number of lawsuits, 1 is 0. So that lawsuit was not successful. Nor was it settled. So wasn't won by the person suing and didn't go to settlement. and it was actually just tossed out. So in the 4 billion flights per year in the history of aviation, and this is not just the United States, this is worldwide. There has been no successful lawsuit. I think people get nervous about the international flight implications, but in reality, like the most litigious place in the world is the United States, and you have really great coverage with the AMAA for the United States, and really the risk of litigation elsewhere is very low. And then, of course, it's never been done. So in terms of preventing in-flight medical emergencies from happening, pre-travel clearance is really the most important thing. So making sure that a patient of yours is safe enough to fly. This is an extremely busy slide, but the what I'm kind of trying to convey here is this kind of makes a lot of sense. There's a really great review from the AFP that was published in 2021 around medical advice for commercial air travel. You could, of course, reference. UpToDate has some more things that are helpful. But really, like anyone with like active, unstable cardiopulmonary disease should not fly until that cardiopulmonary disease becomes more stable. Anyone that's had a recent surgery is going to have specific timelines given by their surgeon around when they can fly. And then certain things like stroke, recent MI, pneumothorax, like they have specific guidelines around how long a patient would have to wait and appear medically stable at sea level before they could safely fly commercially. So I don't want people to get totally bogged down and lost in this slide. There are a lot of really easy references through the AFP through UpToDate that you can get kind of on the fly in clinic if you did have a patient who was asking you if you felt like they were safe enough to fly. So in terms of your patients with cardiac or respiratory disease, really any patient that has a baseline oxygen saturation of less than 92% really should be considered for in-flight oxygen. And this can be navigated through the airline directly to provide that oxygen. And the patient would just need physician documentation for the necessity of the oxygen, how much oxygen, and that with that oxygen that they're medically cleared to fly. And then passengers should be able to walk 50 meters and climb one flight of stairs without angina or severe dyspnea, as just kind of a general thing to kind of keep in mind for clearance. For DVT, there's a few different things that really increase the risk of DVT around flying. One thing to keep in mind is just the time in air. So the risk increases significantly with flights that are more than 4 hours, and then kind of peaks and levels out at flights more than 8 hours. Mechanism here, in addition to the prolonged sitting, mild hypoxia decreases venous blood flow. It promotes this kind of mild inflammatory state, and it can and that itself can activate platelets. That's in addition to the prolonged sitting, the patients maybe being a little bit dehydrated. There was a population-based study that kind of followed these 9,000 business travelers over 4.5 years. And from this, they kind of determined a risk of like 1 in 4,600 occurrence of DVT. The risk is going to be significantly higher with patients that are passengers that are immobile, that are dehydrated, that have hypobaric hypoxia, meaning, if you're a passenger that's coming in with a sea level oxygen saturation low 90s and is riding in the 80s during the flight. And then other kind of individual risk factors around obesity, malignancy, certain medications like OCPs, history of hypercoagulable states. An interesting thing I came across in one of these like retrospective studies is that the aisle seat was associated with a lower risk of DVT compared to middle and window seats, and they attributed that to ambulation in the flight. So patients that are on the aisle seat are more likely to ambulate and have a lower risk, therefore, for DVT. In terms of counseling patients for prevention, especially if they have any of these risk factors or multiple of these risk factors, adequate hydration, mobilization at least every 2 hours, and then consider prophylaxis for high-risk individuals. One thing that I felt important to convey here is that if you're ever in one of these in-flight medical emergencies and have the very, very, very rare occurrence of a death during the flight, it's important not to declare the death. So there are legal implications, mostly for the patient around, like, I think life insurance and other kind of things, like civil legal kind of things that vary significantly country to country. So you can kind of tell the pilot and the flight attendant like a presumed death of the patient. You can stop CPR after it's kind of deemed that full resuscitation has been is not going to change, or further resuscitation is not going to change the outcome. But you don't want to like officially declare death. And if available, best to kind of do this in consult with those ground medical services. So if we went through this whole entire lecture and you forget everything, another helpful resource is this app called AirRx, which is really great. It's a free app developed a few years ago, but it's been updated since I last gave a lecture like this by experts in aerospace medicine, emergency medicine, and ground medical to help improve IME preparedness. It's so specifically designed for health professionals, no matter kind of where you fall in that health professional role, who are just not used to responding to acute events on a routine basis. It goes through a lot of the things we talked about today around, hypoxia, gas expansion, decompression, sickness, and why these kind of increase the risk of some of these situations. So, an example of how this might work, you're on this kind of main page of the app. They have these top diagnoses kind of listed here. And if you pick one, so here we pick syncope, near syncope, it'll give you equipment, medications you're going to want, how to kind of get them started in their care, evaluation of the patient, questions you're going to want to ask them, history you're going to want to get, and then recommendations on treatment and management of that patient. So here's a breakdown of kind of historical questions that you're going to want to get, what your exam might want to include, and then kind of initial interventions to help stabilize this patient. So this doesn't need internet to work if you have the app downloaded, and can be, especially if you're like, oftentimes there's more than one person responding to these events. One thing to keep in mind is that it's helpful usually to have more than one person there, but of course there can be too many people at times. So if there's someone there that you feel like is more qualified, it is actually helpful, especially if you have something like this that can kind of help guide the care, make sure things aren't missed, as a resource for you kind of right there. Okay, getting back to our patient here from my flight to Phoenix. When I went back and evaluated the patient, I found a middle-aged white male with dizziness and lightheadedness. He was alert, reported feeling like he was going to pass out. He described kind of poor PO intake for fluids over the past 24 hours. Wasn't reporting any chest pain, no shortness of breath, didn't have any other kind of concerning neurologic changes. He reported that he had a primary care provider, which is an important thing to gather because there are people that, of course, have limited access to care. So they might have like kind of undiscovered, even if they don't tell you they have any significant past medical history, they might have unknown cardiac and pulmonary disease. So important to see if they do have someone that follows them regularly. And then told us he was not on any prescription medications, denied any recent alcohol or drug use, and denied any tobacco use. When we did his exam, I put like his blood pressure was about 160/100. We had this like very dodgy radial cuff that was quite inconsistent. What I did know is that he wasn't hypotensive, which is all I really cared about for his like kind of pre-syncopal presentation. His heart rate was a little bit elevated, respiratory rate was 16, and oxygen saturation was 92%, which would be, considered fairly normal. On his exam, he was pale, appeared a little bit anxious. He had kind of like beady sweat at the temple. His neurologic exam was pretty unremarkable. He's a little bit tachycardic. His rhythm sounded normal. He had strong pulses. His lungs were clear. He was able to speak in full sentences. He's definitely dry mucous membranes. And then his skin was a bit warm and moist. And then in terms of medical kits, this is kind of what I expected to find when I was given, when I asked the flight attendant to grab the emergency medical kit. In reality, it looked more like this. So airlines they're getting better about this because there's more legislation coming out. But I felt like I got like this duffel bag of random medications and medical supplies that was just kind of all over the place. So the person that was helping out with the emergency with me was actually pretty helpful in terms of just trying to organize some of the medications that we were considering using. And then pilot was updated and had requested EMS meet us at the gate. We were only 30 minutes out from Phoenix, so even if this had been a more significant scenario, Phoenix would have still been the closest airport for us to get to. And then in terms of our assessment plan, so first determination is stable versus unstable. So the patient appeared stable. We did our best from just kind of history and physical exam to kind of rule out any of these more life-threatening acute issues. And then our differential was like the patient was likely dehydrated and either had an orthostatic or vasovagal kind of episode. We gave him some juice and some water. The flight attendants were able to clear a row, and we were able to lie the patient down and elevate his feet. And then kind of with this, over the next 30 minutes until we landed, the patient had improvement in symptoms. And then when we landed, EMS boarded, we gave a report to EMS, and then the patient was assisted off the plane. So for him, not a terribly complicated scenario. A few different things likely contributing to his clinical picture, but luckily he was quite stable and did well. There can be all sorts of different things that you can encounter for these emergencies, and luckily his was not too severe. Final things I wanted to kind of discuss before we kind of break off for questions. Recognize that space is going to be limited, so flight attendants can be helpful to identify a place to move the patient to. They can help reorganize other passengers to make more space available. Again, if another individual feels you are more qualified, it still might be a good idea to have them stay by to kind of help with giving medications or with additional interventions. Consider downloading that AirRx app because it's free and it is really nifty and helpful. Remember that your medical legal protections exist, and then that to date in the whole world and billions of air travelers and thousands and probably hundreds of thousands of in-flight medical emergencies, there's never been successful litigation against anyone, and really has only been that one case that I was able to find that someone even attempted to litigate. And then finally, one of like the probably most important things here is that it's never going to be your decision to divert a flight. So the pilot might ask for a recommendation around flight diversion if you feel like the patient is unstable enough that the flight should be diverted. But ultimately, that decision is always going to lie on the pilot. And you might say, this flight absolutely needs to be diverted, and they may not, because they are weighing a lot of other different things. Whether around different areas and whether diverting the flight could pose a risk to other passengers, financial implications of flight diversion, whether the nearest airport can even accommodate the plane to land, or if there's even the medical interventions that you feel the patient needs, are they even available anywhere close to a divert airport? So don't worry about that ever being a decision that you have to make. It's just a recommendation that you give the pilot just based on if you think the patient is stable or unstable. But ultimately, they will make that final decision. If they're talking to ground medical, they're the ones that make that recommendation. And then these are the resources I used. Again, the most helpful one was probably that JAMA systematic review, and then that New England Journal Medicine article. But that AFP did publish in 2021 kind of an overview of in-flight medical emergencies that is also a good resource to take a look at. And that's it. Thank you all for listening, and then I'll take some questions.
A funny image, as well as what is that movie called Airplane, right?
Yeah.
From when I was a kid. Thank you, Dr. Pennings. Really interesting presentation. There was a little bit of activity in the chat around that AirRx, and I think Dr. Woodhouse provided an active link. So you may just want to check that out to see if they're getting that right. And sure. I would welcome others to type questions into the chat or unmute to ask your question of Dr. Pennings.
So Jeff, a little anecdote. We had I believe it was a Boise physician, or at least an fMRI trained doc, who ended up delivering a 28-weeker en route to Hawaii. And the plane had just passed it takes longer to turn around than it does to keep going. I don't know if you remember hearing about that, maybe a couple of years ago. It was kind of exciting. Kiddo and mom did great, but glad there was a family doc on board.
Any other questions? I bet you all are wondering if you'll ever need this information, but now you have it. I know, I think I've heard Dr. Mickelson share a story about an in-flight call that he took. But anybody else have a story to share?
I've had a couple. They weren't as exciting or as straightforward as yours, Jeff, but yeah.
Well, this has been recorded and will be in the CME library in the next couple of months, as soon as I can get it uploaded and all that done. And Dr. Pennings, would you please send me the PDF so I can share that as well? And I'll send out the CME certificates. Is there anything else you'd like to say?
No, the link that someone had listed here is how you can get the app.
Great.
So that's good.
Great. Well, please don't forget to fill out the Google form that I've shared in the chat to get credit for today's CME. And our next CME is with Full Circle Health Boise on July 8th, and topic is forthcoming. It will be with Dr. Katie Myers. Thanks, everyone, and have a great day.